computer. Okay.
Okay, admit all.
Go for it.
Hi.
Hi, everyone. Oh, quite a collection.
Aspetta.
Right, so, yeah. So, Mary, would you like to kick off?
Hello everyone, welcome. I'm Mary, I'm the marketing manager at London Sports Orthopaedics, so I think I've been in touch with all of you at the moment, before now. So it's great to see so many people attending. Firstly, I'd like to introduce Mark. So Mr. Mark Phillips, and a wrist surgeon at London Sports Orthopaedics. Most of you know Mark already, or a lot of you will know Mark already. But if you don't, I would say he's undoubtedly the top hand surgeon in the UK, specialising in treating musicians' hands. And you'll get a real feel today for his incredible skill and his expertise in treating musicians' hands in such a unique way.
He's stomping. He's stomping.
I think I've just muted Katya. That seems to have done the trick.
Yeah. And
so, thank you.
Mark wants to make this session today as interactive as possible. So if you'd like to ask a question as we go along, can you use the chat function, but also we're going to have quite a long or a decent Q&A session at the end. If you'd like to be seen, then please put your video on, but if you're eating your lunch, you might not want to. Probably keep muted unless we want to ask a question. So really over to you, Mark, if you want to.
Thanks very much, Mary. Yeah, I'll just share screen now and we'll get started. Thank you for setting this all up for me, Mary. So I've given a few of these Zoominars now, and it is really nice to be able to see people in the ribbon alongside, seeing people's faces and seeing some sort of interaction. Makes it feel like you're not just sort of talking to yourself, but I suppose when you're giving a presentation, it feels like that anyway when you're talking to an audience. I'm
trying to find somewhere that I can do this. No, I'm fine.
Could you mute yourselves if you're going to be speaking in the background? So, and Mary, you'll go through mute everybody, would you?
I think I thought I already did that, but let me check.
There's a couple more, I think, that just need muting. Babies and dogs shouting in the background. So yes, we are recording this session so people can watch it later on. So this is a talk about musicians.
Mr. Phillips, I think you're on mute.
You're muted. You're muted.
How did that happen?
Sorry. You're back on now, Mark, I think.
Good. That must have happened automatically. I didn't do that. Bizarre. So yeah, I've been a hand and wrist surgeon in London for 15 years. I was general orthopaedic surgeon, first of all, working at King's, working privately for the last 5 years. And thanks to John White, he got me started on all of this. John White, hand surgeon in Hendon, also a very accomplished percussionist, also hoping to join us from Australia now, where he's now setting his practice in Australia. He heard that I'm an amateur trumpet player and was very keen to leave me this practice. And then I was lucky enough to inherit the practice off Ian Winspur, who has really been the doyen of musicians' hands in London for the last 25 years. And he's now 76 and is allowed to have a bit of a rest. But he serves as a very useful source of knowledge for me whenever I go to him. And I've even sort of joined John White in Australia for one of his Zoominars as well. when I first met John 5 years ago, I didn't even know that musician's hand was a thing. I'd never even thought of it as a subspecialty. And then I read Ian's book, and he's now got 2 books on the subject, which are here. And I've absorbed both of them as much as possible. They're amazing works of summarizing 25 years worth of experience. And it is a specialty. It's as much a specialty as sports orthopedics is, but for some reason doesn't seem to have taken off in the same sort of way. So I'm going to try to persuade you that it is a subspecialty, and that it needs to be expanded as such. This is the poor old fingers of the guitarist in one of the bands I play with. I'm a keen amateur jazz trumpet player, and I play on a Wednesday night in New Malden Cricket Club with a bunch of guys who are in their 80s and can't stop playing, and Charles's fingers are still looking a bit worse for wear after a lifetime playing jazz. So I've already told you how I got into it. It landed on my lap, essentially, with John White handing me the practice, and then Ian Winspur. And along with what John did and with what Ian had done, they went along and did clinics at BAPAM, the British Association for Performance Arts Medicine, which for 25 years has served as an amazing hub for people to get medical advice from all aspects of performance arts medicine, not just musicians, although 70% of people that call BAPAM are musicians. The other 30% will be actors, stage crew, dancers, etc. And of all the people who are musicians, about 50% of them have an upper limb problem. Of course, the upper limb is the most crucial thing for playing a musical instrument. And if you think about it, there aren't really any musical instruments that you can play without your hands, or that you play without your hands. And BAPAM essentially do a huge amount of triage work for us and find the right person, whether it's a psychologist or a physiotherapist or a back pain specialist. And they send me 3 patients a fortnight that I now do on Zoom, but they also send me patients directly to my clinics. Most of them are not insured, and many of them I see as NHS choose and book patients. BAPAM have got a new website since I did this slide, and the new website looks absolutely fabulous. Now, here's a thing. I wondered if we were going to be able to do a hands up, but it's not going to work in this because I prepared this talk for another forum, and I was talking to a whole load of orthopedic surgeons, and I wanted to find out how many people would call themselves a musician. And it's the same as being a sportsman, essentially. You're never quite sure whether you are one or not. Now, there are people in this talk today who are definitely musicians because they've spent their whole lives as musicians. And then there are other people like me who are amateur musicians who occasionally have picked up the instrument in the past at different times in their lives and not sure whether they classify as a musician or not. And it's the same with sport, essentially. And you can't do any studies to find out how many musicians there are in society for exactly those reasons. You can set different parameters to define a musician as to whether they earn the primary part of their income from being a musician. Of course, these days, that would be very few. And then you could say, well, you're somebody that plays every day, or whatever criteria you use, you get different numbers of people in society. But I use the figure of about 1 to 2% of people would probably call themselves musicians. And that's quite similar to the number of people that might call themselves a sportsman. So this is what I've noticed, is that sportsmen get an awful lot of help. And I've been trying to whoop up a little bit of enthusiasm for some anger amongst musicians that they don't get treated in the same way that musicians do. The ISEH was set up in Tottenham Court Road in response to the need before the Olympics, and it was a partnership between the government, private institution, HCA, UCL, and the NHS, and it is an excellent service. But if you think about how often you see sports clinics in towns, I think most of you, whichever town you come from, would be able to identify a sports clinic somewhere in your town. And none of you would be able to identify a performance arts medicine clinic in any town that you live in, I would guess. And so that's the difference. There are almost similar numbers of sportsmen and musicians around, and a huge difference in the amount of help that's available for them. And the clinical problems that musicians get, I would argue, are probably as common as the problems that sportsmen get. And what I've learned from working in London Sports Orthopaedics, where I work with some sports physicians who are working in a specialized domain of being a sports doctor, is that in high-level sport, you actually have a team doctor, a team coach, and a team physio. So Cal Palmer, for example, who worked with Leicester Tigers, worked with us for a long time. He knew an awful lot about rugby. He worked with a coach who knew an awful lot about the injuries and how to avoid them in rugby. And he worked with a physio that knew an awful lot about rugby injuries. And the same goes for top-level tennis, climbing. Mike Hayton in Manchester has given an excellent symposium on bringing together people who specialize in coaching people with hand-intense sports like badminton, tennis, climbing. And it shows how if these people have an overlap of knowledge, they can really provide the highest level of care for their sportsmen. And this Venn diagram that I have here is about the overlap of knowledge between the team physician, the team coach or tutor, and the team therapist. And many of them would also have, there should be a fourth part in this, but it's difficult to draw a four-circle Venn diagram, would be a psychologist. And I would argue that occasionally you'd need to bring a psychologist into this Venn diagram. And my mission is to try to improve the amount of knowledge that sits here in this middle part for musicians. So I've already stressed how common this is. I mean, everybody knows that works in musculoskeletal surgery, that knee surgeons have a very close relationship with their sportsmen, shoulder surgeons do as well, hip surgeons do as well, foot and ankle surgeons have their ballet dancers and all sorts of other sports that they're interested in. And hand and wrist surgeons haven't really had a big role to play in sport. Most things you can strap it up and get on quite well if your hand's not working well. Not a lot of sports are hand intensive. But of course, music is a big thing for hand surgeons, and it's probably the commonest part of the body to become injured if you're a musician. And so I've been really busy since I took this on, and I don't know how busy hand surgeons would be around the country if they took it on too. Interestingly, I've just identified a potential new area of work, the esports world, where people are timed very precisely as to how quickly they can kill in first-person shooter games and things like that. All their parameters are worked out exactly. And so speed and agility and strength on esports with computer games, which is now big money, and some of these people are sponsored to play at Wembley and places like that, they are more similar to musicians in terms of their needs than other sportsmen. So I hope I'm beginning to persuade you that this is a subspecialty of its own. And then, of course, there comes all of the problems that there's the jargon and understanding the interface. And so that tends to put a lot of hand surgeons off getting involved in this if they're not people who are comfortable with some of those things. And because I am a musician and I spend some time in bands every week, I'm in rehearsals with 2 different bands, I get to see people on piano, drums, guitar, saxophone on a regular basis. I've played in orchestras, brass bands before, so I know how things work. And since I've taken this work on, I've been looking much more closely at how the instrument impacts on the human that's using it. And I spend time doing that, and that helps enormously, I think. So there's musical jargon talking about octaves and trills and things that people are not familiar with, and they find that off-putting. There's not understanding the interface, not knowing what a cor anglais looks like or what the contact points are with a French horn. The physical and psychological demands of the instrument, a lot of people misunderstand. For example, I know Gabriella Dell'Olio, who's a harpist, will tell me that lugging the instrument around and tuning the instrument is quite a lot of work, as well as having to play it. And then you often get this thing that I call subthreshold pathology, where there's nothing much to find on scans or x-rays or nerve conduction studies, and you have to go back and do your examination very carefully, because what's compromising these musicians is so mild that you wouldn't normally treat it, but it's enough to knock them off the top of the game, and that's why this is really important. They present early as a result of that. They're very quick to notice a lack of sensitivity if they're got carpal tunnel syndrome, if they're a violinist, for example. And the tiniest amount of compromise will stop them being able to perform at the top of their game. And of course, the other thing that people don't really want to engage in this with readily, surgeons and patients, is that the chances of a catastrophe are ever present, and there's this huge amount of jeopardy that threatens the situation. So I've said already that it does help that I'm a musician. These are some nutters that I play with in a band. And this is the band in New Malden that I play with, and I asked them if I could film them playing. And you can see there that when you start to look at this field, you start to look a bit more carefully about what the different bits of the hand are doing. Mike on our bass, he's got a 5-string bass, and whether he's picking or plucking, where his hand is sitting, whether his wrist is flexed. And then you've got a fella on drums. Here he's using parallel grip, doing the hi-hat. And then here you can see him on the snare, doing some rim shots. And then you've got Roy on his sax there, a nice old sax, lovely old Selma. And you've got me on my trumpet. Trumpet players very rarely have problems. I think we're very robust people. But it'd be surprising how many people, even I've talked to musicians who don't know what the contact points with the trumpet are and how you might press the valves differently. You can press them with the tips of your fingers or with the middle phalanx, and hold the instrument with one hand using the little ring in your little finger and your thumb under the lead pipe. So there's lots of, and then there's the left ring finger, which works the third valve slide that tunes that. And so there's a lot of jargon, basically. And it's good to know about that stuff. So what conditions do musicians get? This is one of the things that people ask me most commonly. Why are they different? Well, no, they're not. Much of the time, they've got the same conditions that everybody else gets: carpal tunnel, trigger finger ganglion, giant cell tumor, tendinitis, but it affects them on their instrument differently depending on what their instrument is. And so some of the effects are instrument specific, some of them are more general. And half the patients I see come with an instrument created problem. I think it's approximately right. I mean, I think we've got Catherine Butler coming in on this talk. We've got some other people who've got a lot of experience in treating musicians as well. John White, I think, may be here. And they will agree that there are lots of instrument-specific problems that we recognize. And I'll talk about this later on, but essentially I work with a lot of technique educators who recognize a whole classic list of instrument-related problems that commonly affect people within their instrument. From Ian's book, this is the incidence of presenting to a hand clinic. So the top 3 that form 60% are piano, guitar, and violin. 60% of the work in the hand clinic for musicians come from those 3 instruments. As I say, I've hardly ever seen a trumpet player. I've seen one trumpet player. And that's on a background of about 5 or 6 new musicians a week in my clinic. Cello comes 4th on Ian's list, and I think it is disproportionately represented because there aren't that many cellists. It's a hard physical instrument. I think we've got Gillian Thode listening in as well, and she knows what hard work the cello can be. The harp is, according to Ian Winspur, is the most disproportionately represented. Not many people play the harp, and a lot of people turn up in hand clinics with harp problems. And so these are the general problems that we see in a normal hand and wrist clinic: tendinitis, trigger finger, carpal tunnel, other forms of tendinitis, ECU tendinitis, very common, of course, FCR occasionally, de Quervain's, all the classics. And then other rarer conditions: tennis elbow, a more diffuse polytendinopathy in the forearm. And depending on the instrument, and lots of instruments, of course, are asymmetric. So depending on the side, it will affect them more or less. And these are well-known instrument-specific conditions. Flautist's finger, where the flute sits on the finger here on the left index finger, can press on the digital nerve over the proximal phalanx and cause a numbness and tingling. And there are ways around that in terms of BOPEP protection instruments, and you can simply put some padding on the finger. You can perhaps look at changing the posture or have the instrument adapted with a U-bend at the top. I know Catherine Butler has views on that. Catherine Butler, being a flautist herself, was able to advise flautists with that experience. Digital neurome is actually quite common. So string instruments at the tip of the finger. It's a condition you don't see in many other occupations, but right at the tip of the finger, the nerves at the tip of the finger can become a neuroma, and they give sharp shooting pains, and it's really about protection and changing the angle of attack on the string. So tape and toughening up the skin and perhaps looking at posture can get around that, but it takes a long time to get better. And then you've got funny things like clarinetist's thumb, where you're supporting the weight of the clarinet on the thumb support, and then you can look at perhaps having a strap around the neck, but clarinetists don't like having a strap around their neck like saxophone players do, and it restricts them. And so you have to find workarounds, and there are lots of them, but you have to know what these problems are and work with instrument technique educators to try to find those workarounds as well. So how's my behavior in clinic changed? Well, it has changed a lot since I've been looking after musicians. My history now commonly takes these things into account. So I always ask them how many hours a day that they play for, and whether that's in practice or in performance or rehearsal or recording studios or teaching. And then you get an idea of how much they play when they're teaching, etc. Now, this Toubiana grid thing is interesting. So Toubiana was a hand surgeon in Paris in the 1970s and 80s, achieved a lot of fame as a very well-known hand surgeon in Paris, and started off a lot of work with musicians. And his grading system, I've sort of strangled it a bit, but essentially I find it really a useful system. It's a 5-point scale that goes down from 5 down to 0. So a patient coming with a hand problem to see a hand surgeon who is a musician would be a 5 if they were still able to practice and play to their satisfaction, but they had a problem with their hand. They become a 4 if they are compromising on practice, but nobody else has noticed yet. So they're still gigging as much as they want to. Nobody's noticed them change their repertoire or reduce the number of performances they do. They become a 3 as soon as they start cancelling performances or other people notice that they're not playing as well as they were. They become a 2 if they're not playing in public anymore, and they become a 1 if they're barely able to practice, and they become a 0 if they can't practice at all. Now, all of that's extremely relevant to your interventions, because of course, if somebody's still a 5, they won't want to stop, and they will want to have as minimal an intervention as possible, such as a steroid injection, some hand therapy, that they allow them to carry on. If they're already a 0, then it's quite, and they've been there for some time, it's quite likely they'll be thinking about more significant interventions like surgery. And it's difficult to make them worse, but surgery can always make people worse. So it's always good to be cautious about that. My conversion rate has dropped significantly from my 20% that it was before I took on musicians. It's now dropped down to about 15% to convert people to surgery. And I do an awful lot of steroid injections for people, which has also been John White's practice and also Ian Winsper's practice. And doing more injections actually than other hand surgeons do. I've learned from Ian Winsper's patients that have come to me that they've had 10 injections over 15 years in for a flexor tendon, say, and they've never wanted to stop to have a trigger finger release. None of those patients, in Ian's experience, went on to have a rupture. It seems completely safe and a sensible strategy. So multiple steroid injections, it seems to suit some people. Even multiple steroid injections for arthritis, polyfocal arthritis in the hand. I was reading my jazz magazine, Downbeat magazine, the other day, and I was reading about a guitarist who pops in to see in his 70s, to go and see his hand surgeon in the States 4 times a year for a steroid injection. So you then ask them in their 70s or 80s, do you have any plans to retire? And of course they say no, because it's more than a job, it's part of them. And so you can't expect to treat them differently when they retire. Their relationship to work and time off is different to people in normal jobs. And it's the only profession that I see people in where it becomes obvious they can't do their job and they start to sob. And I get through quite a lot of tissues in my clinic. It's often important to find out whether it's their primary income source. And these days, of course, many musicians are scrambling around to try and find out whether they can have an alternative income source, because music has been decimated by COVID-19. And then they're also often seeking potential funding for intervention, and I can help them with that because BAPAM is excellent at signposting to extra sources of funding for intervention if necessary. I go through my examination much more carefully now because imaging may be normal. and the standard technique for doing musicians clinics is to see people on their instrument. But of course, if their instrument is a big one, if it's like it's a church organ or a set of drums or a piano or organ, you can see them on their own instrument in their own home by using video. So I've found during lockdown, this whole thing has improved enormously, and the reach of my clinic and being able to work with technique educators has improved enormously through Zoom. And I've learned a lot about things by doing these Zoom sessions, for example, with Paul Anders Sogard. I've really found it amazing to see how many different postures you can get away with when playing the guitar. And there are some people, of course, who you can't help. It's Angus Young from AC/DC. I know we've got some Australians with us today. We'll admit Nicola Goldsmith, she's just arrived. Hello, Nicola. And it's important to know if somebody's got a hand injury, whether they can still carry on playing their instrument. And because of the way that the fingers block the holes on the chanter of the bagpipes, this chap who had septicemia and was on a national newspaper and lives in Glasgow, has been able to carry on playing the bagpipes because he lost the tips of his fingers with septicemia, but was able to carry on because he was lucky enough that the chanter holes can be closed by the skin over the proximal phalanx. Well, that's gone too far. This fella was also seen by Ian Winspur way back about 25 years ago. This is Tony Iommi from Black Sabbath, of course, and he went full-time professional, and the day before he left his factory, he burned the tips of his fingers off and could only play power chords, and of course then created a whole new genre of music. And he has been playing with prostheses throughout his career and has done very well despite that. And here's another guitarist who did very well with only two fingers. This is Django Reinhardt, legendary jazz guitarist, gypsy jazz, and he was at a gypsy fire and burnt his fingers just before going full-time professional as well. I have found YouTube to be fantastic. People are sending me videos. This is one of the first videos I looked at with this fella who was having problems with his left ring finger, and I think you'll all be able to see that when I slowed it down, you can see the ring finger just goes into swan neck there. So we'll just watch that landing again on the black keys. When he hits there, you see his left ring finger swan necking, and he couldn't believe it himself, but it was irrefutable evidence once I'd managed to find that. So it's really helpful to be able to use video. They can all video themselves with their iPhone now and put it in a position where you can see the hand up close. Sometimes you'll take advantage of video that's already available for the public online, and you can watch musicians play in their natural environment and see if you can see any clues to things that might be low-hanging fruit for an intervention. And these are the typical interventions. And I find that if all the investigations are normal, as they often are, then I often appreciate the advice of a hand therapist, putting somebody through some provocative tests and coming back with a working diagnosis. I find that steroid injections are helpful as a way of getting closer to the diagnosis. Even if they don't help, it tells you that it's probably not that problem that you thought it was. And working with technique educators not only allows me to have a really good look at people with their instrument, but it also allows me to be able to do that with some specialist advice on hand as well. So that's been really terrific. I've also written a new website during lockdown, musicianshandclinic.co.uk, and I put some blogs on there. There's some very interesting ones. I think the most looked at one is one on finger yoga, which basically looks at how to stretch your intrinsics. And that seems to be something that a lot of musicians like to do. It seems to, they don't do it. They've never done it before, but of course their intrinsics are often very tight. And then stretching them is often shockingly, they're often shockingly tight, and they find it helpful to do some stretches on that. And I explain how the intrinsics work as best I can. Anybody who knows about the intrinsics know how difficult they are to understand. And I've also written another one called The 5 S's That Musicians Notice. And these are the 5 S's here. And you'll all recognize that basically musicians immediately notice when they aren't as strong as they were. So if they find that they can't play at forte, they can't move at speed. So those semi-demi quavers don't come out at 240 beats a minute as they used to. Their span is reduced, so they've got these amazing metrics, so they can spot when they can do a 10th on the white keys, but not a 10th on a white key and a black key. And they know that straight away. If they've got a little notatory chord from Dupuytren's contracture, which is stopping their span, they'll notice it very quickly and come for early treatment. Needle aponeurotomy might be good for that. Sensitivity, some patients haven't even lost any sensation. Their nerve conduction studies are normal, but they just know their proprioception isn't the same, or they just don't feel their vibrato the same as they did before, and it's a very subtle thing. And stamina, of course, how long people can play for, and some musicians are required to play for very long periods of time in very awkward positions. So yes, you can ergonometrically adapt many instruments, often quite expensive, and a last resort for some people. You can do minor ergonometric adaptations too. And some of our very experienced hand therapists who we have on this talk today are experts at finding workarounds in that way. And when you come to surgical considerations, of course, then there are all these classic considerations such as what position you might fuse an interphalangeal joint in, or where you choose to put your incision, and make sure you don't get it on the pulp of the finger if the pulp of the finger is really important for sensitivity. And of course, managing expectations, having a very frank discussion with the patient about how long they'll be off practice, off performance, when they might be able to return, and what the possible range of options for that is. So I'm doing pretty well for time. I think it's just over half an hour. So, so in summary then, this is challenging, but I found them a hugely rewarding group of patients. They're very intelligent, extremely well motivated. It gets very emotional when things go well or badly. They're the same problems that everybody else gets, but it has much more devastating effects on them. Investigations are not normal, as I've said. You have different windows of opportunity for intervention. Nowadays, of course, everybody in lockdown is asking for their interventions now because they have never had so much spare time on their hands. And strategies for intervention are much more holistic. So it's co-working in multidisciplinary environments with educators, hand therapists. But because they work so hard, I mean, if a musician was used to doing 4 hours of practice a day, they'll do 4 hours of hand therapy a day. And they can use their instrument as a way of rehabilitating as well. And they find it much more pleasurable. You know how it is with most patients. If patients aren't musicians, it'd be very difficult to get them to do more than 10 minutes or 5 minutes of hand therapy a day. So they do very much better, and they're on your side. So essentially that's that. I'm happy to take to questions now. Shall I stop my share? I'll stop the share, I think. Good. I hope that was okay. Good. So
Mr.
Mary, have you
Phillips,
got any questions?
Sorry, Mr. Phillips, I don't know if you can you hear me okay?
Yes, who's that?
I'm Farah Jawad. I'm a consultant in sport and exercise medicine. I work at Homerton University Hospital.
Okay. Do you want to put the video on? It'd be nice to see you.
Oh yeah, of course.
Hmm.
Let me see, is it working? Oh, I'm
Hello,
slightly
Farah.
out of thing. Hi there, hi, nice to see you. I just wanted to say that I totally share your view that this is a subspecialism. And in fact, I did my master's at UCL in performing arts medicine, and I was taught by Ian Winspur. Yeah. So, in fact, I think you might have lectured us. Yes, you've lectured us too. You lectured us too, Mr. Phillips. So I completely share your view that this is a group of people that are that maybe in the past, have found it difficult to find people who have an interest in their problems, and the same applies with dancers as well, of course. I just wanted to also let you know, because I know you said at the beginning of your talk that unfortunately there seems to be a poverty of people in sports medicine who may have some experience in this niche group. I just wanted to let you know that if you do have patients that need NHS input from a sports medicine physician sort of point of view, that you're welcome to refer them into our service. Our patients can be seen face to face. We've got video appointments, we've got telephone appointments for follow-up patients at the moment. And
where is that, Farah?
It's at Homerton, which is in Hackney in East London, and we can accept referrals from all over the UK. Patients need only be referred by their GP via ERS, which is the electronic referral system.
Yeah, that's interesting, because that's the service that I use for getting patients to be referred to my NHS Choosing Book clinic at Hendon as well, which is what John White set up.
Yes.
And it's an amazing service. I hope that can be replicated in other places too. But yeah, that's really good to know about Homerton. So that's good, yes.
Yeah, so maybe it might be useful to you if you've got anybody in the East, for example, who can't travel or whatever, just bear us in mind, because we are here. And as I say, I have an interest in this group of people too. So thank you.
Thank you, Farah. Do we have any other questions?
Can I ask?
Yeah. Yes, Mr. Maymaris, yeah.
Hi, I am...
Would you introduce yourself?
Yes. I am a violinist. I am from Cyprus and I study in Greece.
Okay.
Violin. 10 months ago, I had a change in my violin bridge. And then the mess started, let's say.
Yeah.
I had an numbling in my left pinky. And I was going to many doctors. I had no idea that medical performing arts exists.
Yeah.
And until in the summer, but I had the surgery in June because I finally found a surgeon who understood what's going on. Yeah. And I had the surgery 3 months ago. My specific question is, after surgery, my hand is now in full function. Let's say I can use it to do things at house, and I'm taking Alexander technique classes in order to
a lot of musicians find that very helpful. Yeah, it's good.
Yes. Do you think strengthening exercises and other therapies?
Yeah, so throughout the world, in fact, we have, I think, with us Nicola Goldsmith, who is the president of the World Federation of Hand Therapy. There are hand therapists around the world who are the people you need to see to get specific advice. And within, hand therapists are basically a subspecialty of therapy. Once they've done the diploma, they tend to do hands and wrists and little else. And within that group, they tend to have a preference for treating sports people or musicians sometimes. And it would be good for you to try to find somebody that is in that direction. Nicola, you're unmuted. You're ready to speak.
Well, I just thought since you were mentioning me, I should say hello.
Yeah.
I do have a contact in Cyprus if you want to contact me via the International Federation of Societies for Hand Therapy website.
I am in Greece now. Do you know?
You're in Greece now. Okay, Greece is even easier.
Okay, I can contact you. Yes.
Isn't Zoom a wonderful thing? Well, we're a connected world. Amazing.
Yeah.
Yes, but it's the same all over the world, unfortunately. We had somebody from Japan sitting in my clinic at BAPAM saying that there were very few people in Japan wanting to provide this service. But hopefully, gradually and steadily across the world, this will improve. And this whole culture can be spread so much more easily now that we've got this kind of technology available to us.
Thank you.
Yeah, thank you. Any other questions? Gabriella, yes. Unmute yourself.
Yeah, it's half a question because I think I know where you're going to.
People who don't know you.
Oh, I'm Gabriella Dall'Olio, and I am head of harp, teach the harp at Trinity Laban Conservatoire of Music and Dance. Oh. And yeah, what I was first the question, and then maybe we can give a little bit more. Maybe, but I mean, basically, if you go to a hand surgeon, I personally would recommend, but I'm also posing it as a question, to work also with a violin teacher to rebuild your technique and see if the numbness might have been caused by something that you were not doing right. Yeah. And in the past, I had, I encountered a girl, we were talking about 25 years ago, who something happened inside her hand and the tendon twisted and she needed an operation, and it took her 4 months to recover. And when she could play the harp again, she came to me for lessons. I mean, I was not thinking anything else, but I thought her technique was a little bit tense. So we worked in a totally different way, really listening to what the hand is happy to do, and trying to push a little bit further from there, because obviously we use the hand in a way that is not completely natural when we play musical instrument, but you need to think naturally and then move away from there, but always aware of what you're doing against the grain so that you're not damaging your hand. And so by working with both a hand therapist, but also someone who can really help rebuild the playing techniques, I think that's extremely important, because if the two don't connect, then you might end up one day with a problem that was similar to the first one.
Yeah, these three-way consultations have been absolutely amazing, Gabriella, and working, you know, and you can do that on Zoom now. And what's more, you can have a four-way consultation as well. So you can have hand therapist, hand surgeon, you can have your own teacher, and then a technique advice specialist who works with people who understand clinical problems. And so, and you can bring anybody into the meeting that you want to. It's really superb. I thoroughly support that, Gabriella. Thank you. Any other questions at all? Does anybody post any questions, Mary, by typing them in?
No, we haven't got anything on the chat.
Okay.
Could I ask a question, please?
Yeah.
Mike Sturgis.
Hello.
Sorry, I'll just unmute my camera.
Where are you coming to us from?
Hello.
Introduce yourself.
Well, I'm actually in I'm in Cornwall on holiday at the moment, but I normally live in Surrey. Okay. So yeah, thanks very much for putting on this webinar. It's been great. And I just was hoping you could touch back again on steroid injections. And I know you mentioned them a bit, and just some confirmation or maybe some further guidance on how many you could have before it started to become a worry. And you did mention that you noted a few examples of musicians who are having them quite frequently, you know, maybe 4 times a year, that sort of thing. Are there any dangers? Should you be aware of any risks? Thank you.
The guitarist I was talking about was actually John McLaughlin, who played with Miles Davis, of course, and still going in his 70s. And wow. He's having 4 injections a year, according to his article in Downbeat magazine this year. Ian Winsper was reluctantly pushed into a corner in his practice, into injecting people rather more than he was comfortable with. In the Hand Society, we tend to talk about 2 or 3 injections and then a law of diminishing returns. And if you look at a lot of studies, you find that about 80% of people get better after 1 injection for trigger finger or carpal tunnel or tendonitis, and often don't seek further treatment over a 2 or 3 year follow-up period. And then another 20 or 30% of people will have a mixed response, not so good. Second injection can be helpful. By the time you get to 3rd injections, it's unlikely to be a long-term cure, and that's why people often recommend surgery. And the big concerns are skin thinning, infection, and tendon attrition and weakness. Skin thinning is a cosmetic concern largely. The infection's vanishingly rare. Tendon thinning and weakness is rare, except for some tendons, the extensor pollicis longus to the thumb, the biceps tendon, the Achilles tendon, and I found the FCR tendon to be, if you inject them multiple times, they may rupture. Whereas the long flexors to the fingers are very strong, and Ian Winsper tells me that in all the injections he did, and he was being pushed into doing more and more, some patients having 10, patients came from his practice to see me in their 70s saying, could you do my 13th or 14th injection? And I was very worried about that. But actually, having talked to Ian, he's had no patients that have ruptured. And I know that that's true, because if they had, they'd go and see another surgeon and get it repaired, and there'd be talk around town about that. So I've never seen anybody rupture a deep flexor tendon, and I think you can keep people going like that. But you're talking about, once you get into 5th, 6th, 7th injections, you're talking about having an injection probably 3 or 4 times a year. It's not consensus stuff, but for some people it works. And the other thing that Ian made a made a subtle art of was giving small doses of steroids for people. For example, you do get a steroid flare the next day, very commonly, and that can last a few days, and that's going to be a catastrophe for a musician who has a gig or a rehearsal coming up. And so you have to be sensitive to that. So what you can do is you can use a small dose of steroids to be cautious, and that'll reduce the steroid flare. It may not be so long lasting, but it may get around that little problem. And the typical cases that I've seen like that have been people where the triggering in their finger is not very bad, but it's just enough to cause a delay that might cause them to play a wrong note, which would be a catastrophe, of course. So so a little dose, so you could use 40 milligrams, 20 milligrams, 10 milligrams, even 5 milligrams to act as a lubricant, effectively, to make the tendon swelling go down and make it glide through those tendon tunnels a little bit more easily. So it's a big part of treatment. And I thought Gabriella was going to suggest that seeing a hand surgeon frightens a lot of people. Because we're called surgeons, they expect we'll operate all the time, but of course we don't. And but we are probably the best placed people, because there aren't hand physicians, we're probably the best placed people to triage and decide on the direction of treatment. I hope that covers your question, Mike.
That's really helpful, thank you.
Good. Any other?
I'm a drummer. Just
okay.
FYI.
Yeah.
Just to add to the mix of everything.
Yeah, no, I see quite a few drummers. It's quite common. And I don't know if John White is with us from Australia, but he's the hand surgeon that set this whole thing up in Hendon, and he is a percussionist, and he was going to try and join us today if it was possible. He's certainly helped out. We've done a joint session with a drummer. The nice thing about drummers is you can see them in their own home. So we have, one seems on a marimba, see somebody on the drum set or on the, and you can do that very thoroughly using Zoom now. Yeah, good.
Thanks.
So any other questions?
Question, please.
Hello, yes. Introduce yourself.
I'm Neil, I'm a physiotherapist at Body Set. I was wondering if you had any advice for someone who's looking to get into that area of work. It seems to be a bit of a catch-22 that you don't get any musicians coming in if you don't have any experience, but therefore it's hard to gain experience. Can you recommend any courses?
Yeah, oh, definitely, yeah. So there's the MSc at UCL, which has been suspended this year. Hara Truly, who also works at BAPAM, you can inquire through BAPAM about it, but Hara Truly runs that course. She's a GP and a pianist. The course has been suspended this year. They're looking at making it an online course next year, so it'll be even easier to attend, doesn't matter where you're from. And they're getting all the material together for that. So yeah, that normally has about 9 or 10 people on it. I've lectured on it a few times, as Farah said. It's extremely fun to do. You see people from all sorts of different backgrounds. There's been sort of aerialists and dancers, as well as musicians and doctors, physios, all doing that MSc. And it's a great way to get to know the network of people that are involved in this area. It's a great qualification to have if you're starting out and you don't feel qualified. I read those 2 books and talked to John White and talked to Ian Winsper, and got a lot of advice from Catherine Butler. And gradually I managed to scramble it all together. Does that cover your question, Neil?
It does, thank you.
There's a question here from Sahid. Is there any particular corticosteroid you'd prefer to use in order to reduce the steroid flare? Would I inject 5 milligrams, for example? A hand and upper limb OT with Bart's Health. Yes, Sahid. I tend to use the most common one, which is depomedrone, which I think is, it is a crystalline form, and it is notorious for perhaps being one of the worst ones for producing steroid flare. Triamcinolone apparently is better. Kenalog, I don't know, actually. I don't want to change over, because I just want to stay with the mainstream of what everybody else seems to be using. And it's worked for me most of the time. The steroid flare is surmountable. And I think you do get steroid flare with the others as well. So whether it's less, I'm not sure. Using lower doses is good, and titrating the dose for the need, I think, is important, as you say. Gabriella says, are steroid injections addictive? They reduce the symptoms. Yeah, they do. They just stop the pain. They basically stop the inflammation and stop the healing, and therefore make the tendon a bit thinner. So if you imagine, I often explain to patients like this, so if you've got a bundle of fibers which are a tendon, and some of them have torn, and tendons and ligaments tend to fail when you ask them to do things that they're not accustomed to. So you change the action, you change the way you're doing something, you've got a new instrument, you're playing more than you used to. You get micro tearing, then they get swollen, and often that creates a vicious cycle of entrapment of tendons. They tend to jam when they're running through tendons because they're swollen. And if they are swollen, they traumatize themselves. When you put a steroid in, it shrinks the tendon down. The intact fibers remain, ruptured ones tend to disappear. All the inflammation goes because all the chemicals that produce inflammation, which are trying to stop you using it, they all disappear because the chemicals are blocked. And your tendon gets smaller, runs through the tunnel. And once you've stopped that, and the steroids wear off at about 6 to 8 weeks, once the steroids have all gone, the symptoms don't just come back because the tendon is now existing of relatively fewer fibers, but a smaller, thinner tendon and running smoothly through the tunnel. They're not addictive, but that's why people come back, is that sometimes you have a slightly weaker tendon, you haven't addressed the fundamental problem, and the tendon fails again. So in that trap, then people are trapped in having repeated steroid injections because they find them helpful. They're not addictive in the traditional way of other drugs being addictive, but people get, I do call them my steroid junkies very often, because there are a group of people that keep on coming back and won't want to progress to surgery for the reasons we've just discussed. Does that cover that? I think that covers that. Thank you, Gabrielle. Good. Well, we've got 9 minutes left. Ideally, then the short-term solution, yes, yeah, exactly. So, and then once you've dealt with the tendinopathy, you can then start building on hand therapy and a graduated return to full levels of performance. And it has to be graduated and very slow. Yeah. I haven't mentioned focal dystonia at all. Oh my God, focal dystonia is a terrible thing. It's a whole talk on its own, and nobody's touched on that. We could leave that alone. It's a dreadful problem. I think we will leave that for today, unless anybody particularly wants to know anything specific about it. But musicians' focal dystonia, where hands start to misbehave, it's essentially a software problem, and needs a long-term rehab. But as long as people get realistic expectations, they can gradually get out of that, but they need to work on it for a long period of time. It's a very musician-specific problem. Good. Are there any more questions? Who have we got here? Have we got any other people? I've got 2 screens here to look at. Catherine Butler managed to get in. She's been having having a busy day. Henry from my company's come in. I don't think we've seen John White, unfortunately, from Australia. He obviously didn't manage to get away from work. Good. I think that pretty much covers it then. Should we wrap it up then, Mary?
Yeah, that's fine. Can you hear me now?
Yeah, can you? I can't hear you, Mary.
Okay. Can you hear me now?
Only just. If you keep speaking, I think I might hear you.
All right, I might be able to hear a bit better. Okay, well, thanks everyone for coming. If anybody would like a CPD certificate, could you email me? I think everybody's been in touch with me and I can send that. And today was the very first of a series of webinar presentations, which we hope to do. So thank you, Mark, for making it such a success. And if you're interested in attending any more of ours, you can also email me and I can put you on our e-newsletter list, which means you'll get automatic invitations to any further presentations or webinars that we do. So I think that's it from us. Mark, do you want to finish off with anything?
No, I just wanted to say that, yes, we'll record this. We'll send this out. We'll send a link out to everybody with it on, and I'll put it up on my website as well, provided people don't mind me putting them up on my website as a video for the public consumption. Okay. Good. Thank you all.
Thank you, everyone.
Okay, thank you.
Thank you very much.
Okay,
bye.
Bye now, bye.